Good afternoon, and a big welcome to everyone. Thank you for joining us today for this webinar in conjunction with World Psoriasis Day. World Psoriasis Day is an annual global event dedicated to raising awareness about psoriasis. Psoriasis is a chronic inflammatory skin condition characterized by scaly patches on our body. Apart from just affecting the skin, psoriasis can also affect the nails and joints. And if inadequately managed, psoriasis can also have a profound impact on our systemic and mental health. So in this public webinar, we have two talks in which our doctors, Dr. Session Afonso and Dr. Kirsten Yeo, will aim to share about what psoriasis is and the treatment options. We will also have a Q&A session at the end, so do submit any questions that you might have. So without further ado, we will kick off the webinar with our first presenter. Dr. Session is an associate consultant at the dermatology department at SGH. He will be introducing us to what is psoriasis, how it presents, and ultimately to dispel the myths about psoriasis. So I shall now pass on the time now to Dr. Session. Dr. Session, on to you.
Thanks, Laura. Let me just share my screen. All right. Good afternoon, everyone. I'm Dr. Sasha Naponzo, and I'm one of the doctors who runs the psoriasis clinic at SGH. So in my segment, I'll be going through some common facts and myths and taking you through these for psoriasis. So to make this interactive, we've set up a Zoom poll. So do look out for that during the presentation. So just an outline, we'll look at what is psoriasis, what does it look like, how can psoriasis affect your life, and how do we treat it? So first off, psoriasis is a contagious skin condition, myth or fact? You can select your answers in the Zoom poll. All right, hope everyone's able to answer. We'll keep the poll open for about 30 seconds and then we'll close it once we've got the answers. All right, let's see our answers then for the poll. Okay, we have some who have answered in the webinar chat as well. All right, great. So 76% say that this is a myth and 24% say that it's a fact. And it's a myth. So psoriasis is not a contagious skin condition. So what is psoriasis? Psoriasis is a chronic inflammatory skin condition. It's based on the immune system. So what this means is that there are many inflammatory cells in your skin, and these, which are usually meant to fight infections, fight off skin cancers, can sometimes work in a wrong way, resulting in skin inflammation. So this inflammation causes rapid multiplication of skin cells, leading to thick and scaly skin. It's found in about 1 to 3% of the population, and in Singapore, that's at least 40,000 people living with psoriasis. Now, looking at the pathophysiology of how psoriasis comes about, it often starts with someone who's got some sort of predisposition to psoriasis. So the person with the genetic and environmental factors that predispose them then is exposed to a trigger. And some of these triggers are poorly understood, but this trigger then activates immune cells which release signals. Now, cells, just like people, communicate with each other. And like we'd send an SMS or a WhatsApp message to someone else, these cells release chemicals into the bloodstream so that they can talk to each other. They release signals which then cause the skin cells to grow rapidly. So normally our skin, which grows from bottom up, matures in about 3 to 4 weeks. But in psoriasis, this happens in 3 to 4 days. And this causes all these dead skin cells to accumulate at the top. Also increases the blood vessels and brings in even more inflammatory cells. So you can imagine how this is almost causes a sort of snowball reaction, causing more and more rashes. Now, I always like to think of psoriasis working as like a symphony. When you go to the opera or the symphony, you hear music, but what you realize is that there are so many instruments working together to create that music. You have your violins, you have your drums, you have the horn section. Now, similarly in psoriasis, you can see in this image that there are so many different types of cells that are releasing signals. You can think of it as each cell making its own music, causing the final downstream effect, which is the red scaly rash. Now, even though this may seem psoriasis to be a very complicated condition, you'd think so, but it would actually work to our advantage because having multiple pathways, that means that there are multiple areas that we can target with medications to treat psoriasis. Now, the next myth or fact, psoriasis is affected by smoking. Can we bring up the poll results, please? All right, we have the poll up here. Psoriasis is affected by smoking. True or false? Myth or fact? Let's put the poll up for a while and let you all answer. And remember to click the answer in the poll section, not the webinar chat, so we can see all your answers. Okay, let's see what answers we have. Psoriasis, is it affected by smoking or not? All right, so 67%, 2/3 of you say it's a myth, and 1/3 of you say that it's a fact. Okay, it's a fact, so only 1/3 of you got this correct. Psoriasis is affected by smoking. So if you have any friends who smoke and have psoriasis, or you yourself smoke and have psoriasis, this is one lifestyle factor that you can use to modify your psoriasis. So psoriasis is often thought to be a contagious condition. People sometimes don't want to touch people with psoriasis, but that's absolutely false. Psoriasis has a couple of aggravating factors, and I'll walk you through them. Number one, stress. When I run the psoriasis clinic, many of my patients come to me with a flare-up, and I always ask this one question: was there any recent stress in your life? And for some of them, it's an exam. For some of them, it was a recent death in the family. For some, it was changing their job to a more stressful role. So stress definitely contributes to psoriasis flares. Another one is injury. So areas of tattoos, areas where you've scratched yourself are more prone to developing psoriasis plaques. Obesity is an interesting one because so many patients who come to me say after they have lost weight that their psoriasis improved, even though I've kept the medication dose the same. So weight loss, because fat cells itself generate inflammatory signals. So obesity aggravates psoriasis. Smoking, as you found in the poll answer, definitely makes psoriasis worse. So even if it's difficult for someone to stop smoking immediately, I say, how about we try and cut down your smoking first? The next is hormone changes. Now, pregnancy is a time where a woman's hormones are going up and down and adjusting a lot. Interestingly, during pregnancy, some patients' psoriasis actually gets better. Some patients' psoriasis worsens or flares up, and some patients' psoriasis stays the same. Infections are a very common trigger for psoriasis. So very often, if a patient has had a flu or an upper respiratory tract infection, they find that their psoriasis flares up afterwards. Same goes for vaccinations, because vaccinations basically work by stimulating your immune system. Certain medications, so certain cardiac medications like beta blockers, certain steroid medications, certain malaria medications can trigger psoriasis flares. And finally, alcohol is another aggravating factor for psoriasis. Next, there is only one type of psoriasis. Can we hear from all of you? Is there only one type, or there several types? What do you think? Is it a myth or a fact? Let's put up the poll, please. Okay, and we can close the poll. Let's see how we fared with our answers. Okay, so very good. 79% say that it's a myth, and only 21% say that there's only one type of psoriasis. It's an absolute myth. There are many different types of psoriasis. And it's important to recognize the different types because they impact us in different ways and often have different priorities or treatment requirements, which lead the doctor to give you different treatments for different types of psoriasis. So what do the many different types of psoriasis look like? It's a bit like asking, what does a bird look like? So the most common type of psoriasis, plaque psoriasis, is the top left. Looks like these very thick, scaly plaques or raised patches that come on your elbows, come on the knees. Common other areas include your belly button area. On the bottom, you have scalp psoriasis, which is another very, very common. Sometimes up to half of psoriasis patients can have scalp involvement. Thick scaly rashes around the hairline, particularly at the back of the scalp. The top right is pustular psoriasis, very poorly understood because people often think this is an infection. The moment they see pus, they think it's either pimples or a fungal infection, and they end up giving themselves the wrong treatment and not seeing a doctor. The same goes for nail psoriasis at the bottom, which is, you can see that there are crumbly, deformed nails with ridges and little dots. And the reason the nail is irregular and white is because the skin actually produces the nail. The nail factory lies at the edge of the nail. And if there's inflammation along the nail factory or under the skin under the nail, that causes the nail to form in an abnormal way. And often this is misunderstood and mistaken for fungal infections. Psoriasis also looks like this. On the top left, you have inverse psoriasis, which does not look like the previous types of psoriasis that we saw. It does not look like any of these. Here, it's not scaly, and it's on the skin folds. So it's, in this lady, it's under the breast. It's flat red patches, almost a bit shiny looking. Guttate psoriasis, the top right, is something we commonly see in children, and sometimes this is the first presentation of psoriasis. We use the word guttate because they look like little raindrops that are scattered over the body. And the last type is erythrodermic psoriasis, the most severe form of psoriasis. So if you imagine psoriasis or inflammation as a tree on fire in a forest, one tree on fire, a section of the forest on fire, looks like the previous types of psoriasis, plaque psoriasis, for example, or scalp psoriasis. But imagine that spreads and the entire forest catches fire. The entire forest is red. This is when you have erythrodermic psoriasis. This patient's entire body is red, scaly, flaky, causing the patient a lot of discomfort. So what does your psoriasis look like? What does your loved one's psoriasis look like? Think of this because that impacts what sort of treatment they get in the future. Now, psoriasis also looks like this. 2 years ago, the Met Gala theme was gold. And Cara Delevingne, an actress and a model, she's famously known for her eyebrows in cosmetic adverts. She painted her entire body in gold. but left exposed only her psoriatic plaques. You can see them at her elbows over there. So she wanted the world to see that she had psoriasis. Kim Kardashian is known for many things, but psoriasis isn't one of them until recently. Earlier this year, she posted on Instagram about her crazy and painful psoriasis flare-ups. So more and more celebrities are bringing to light this skin condition. Psoriasis also looks like this. This is a paper clipping from a newspaper in Australia, where a teenage girl went out for a fun day at the pool with her friends. And just as she got undressed, this lady came up to her and said, she pulled her aside, didn't even say hello. A lifeguard did this. And she said, have you got chickenpox or something contagious? And embarrassed the girl in front of everyone. Everyone started to look at her. And this actually made it to the papers. Imagine how you would feel if someone pulled you aside on the MRT, pointed at your skin, and got the entire train looking at you. Psoriasis also looks like this. It's often associated with stigma from friends, from classmates. Children often ask, they point at people and ask, Mommy, why is that man red and scaly? What's wrong with him? Psoriasis often comes with joint pains, and that can impact activities of daily living. Psoriasis also looks like this. Imagine having psoriasis and not feeling comfortable to post a picture of your skin, of your face, because you can see some of the visible plaques. And as you'll see later in this presentation, psoriasis also comes in the way of relationships, causing significant stress and putting couples further apart because of the skin condition. So as you can see, psoriasis is an inflammatory condition that significantly impacts quality of life. Looking at some numbers, 60% of patients consider psoriasis to have a major effect on their quality of life. 90%, that's almost everyone, feels stigmatized. And that actually doesn't that make you think about how we should think about other people's skin conditions? About half of them, 52%, report significant psychiatric symptoms, all the way from low self-esteem to body dysmorphia, depression. 91%, again, almost all psoriasis patients, report lower self-confidence from their disease. And I'd like you to take a minute to pause and think here. How does psoriasis affect you or your loved ones? How does psoriasis affect that colleague at work? The one who you've seen is red and scaly, has patches, has to brush their desk with a wet wipe before someone comes to visit them. Think of how psoriasis might affect their lives. Okay, next up, psoriasis only affects the skin, nails, and the scalp. Myth or fact? Let's put up the poll, please. All right, and hopefully most of the answers are in. We can see what we have on the answers. Okay. So 73% think it's a myth, and 27%, so about 1/3 of you, think that psoriasis only affects the skin, the nails, and the scalp. Myth. So psoriasis affects more than just skin. Psoriasis affects your skin, but it also affects your joints. It increases your risk of diabetes, of cardiovascular disease. It affects your nails. And as you've seen in the slides before, there's a major psychosocial impact on patients with psoriasis. So first off, psoriatic arthritis. I told you that psoriasis affects the joints. What happens here is that the immune system attacks healthy joints. There's joint pain, joint stiffness, and swelling. It can happen in about 1/3, and that's a big number. 1/3 of patients with psoriasis have psoriatic arthritis. But here's the trick. You can even have psoriatic arthritis without psoriasis. And it's important to treat psoriatic arthritis early because early and effective treatment of the arthritis can prevent deformity and destruction of the joints. If we leave it unchecked and untreated, psoriatic arthritis can cause permanent joint deformity and destruction. Now, just some of the symptoms that you see in psoriatic arthritis: joint pain, foot pain. It might be even at the Achilles heel or the bottom of the foot. Very commonly, we see swollen fingers and toes. So looking at the small joints of your body, reduced range of motion. The stiffness is usually worse in the morning. And these patients don't just have joint pain, but they're also very tired. They have eye pain and eye redness, and they can even have pain at the tendon, where the tendon inserts into the joint. And finally, they can also have nail changes. So next, psoriasis and cardiovascular disease. So 50% more likely to develop cardiovascular disease. And if you've not heard of the metabolic syndrome, this is basically a constellation of conditions that increase your risk for heart attack and stroke. So increased body mass index or increased abdominal obesity, diabetes, high blood pressure, and high cholesterol. These conditions are more prevalent in people with psoriasis. As you can imagine, the risk increases with the severity of your psoriasis. So you saw the picture of the gentleman who was entirely red, erythrodermic psoriasis. His cardiovascular risk would be higher than, say, another gentleman his age who just had a bit of scalp psoriasis. Now, I'm not telling you all of this to frighten you or make you feel scared, but rather I'm telling you this to empower you so that you realize the importance of an annual health screen. If you have psoriasis, please make sure you check with your polyclinic or your general practitioner once a year whether you can do an annual health screen to look for high blood pressure, high cholesterol, and diabetes, just a screening. And of course, improving your lifestyle, exercise, a proper diet, so that you minimize the risk of these conditions. Psoriasis affects loved ones too. Now, this year for World Psoriasis Day, the International Federation of Psoriasis Associations picked this theme, which was psoriatic disease and family. And they released this booklet, which you can also see online. But I'd like to draw your attention to this one bar chart here, which was a survey on the impact of psoriatic disease on family members. So living with someone with psoriasis in your home increased your household work. So about 70% of these patients said that increased household work. And this makes sense. Often they have to sweep or brush off the scales left around by their loved ones. They need to wash or wipe off residue of some of the creams, some of the ointments or treatments that their loved ones use. There's a psychological pressure for these patients, family members, and it impacts their social life. Almost 60% of patients, family members said this. It affects holiday planning. Imagine you want to go out on a nice tropical beach holiday, swimming, time spent at the beach, but your loved ones feeling conscious about wearing a bathing suit because it exposes their rashes. That impacts your holiday choices. It impacts daily activities, social relationships. What if your loved one does not want to go to a party because of how they feel about their skin? Only a very small percentage said it didn't impact them. Now, these are just some quotes from this report from real patients. The first one says, "It's affected my social life tremendously. I don't have a social life when I'm so worried about how she's feeling and how other people are making her feel." The second quote talks about how their two young daughters are embarrassed to be around dad because when he wears shorts, his plaques look so bad. And another talks about how their family has to brush off themselves before going out. Absenteeism is a huge issue, both at the family level, but also at the national level in terms of the workforce. So having to take days off, both my husband and I, it's not a quick trip here. We have to drive 4 hours to the nearest pediatric dermatologist. Another one had to miss 2 months, took 2 months of medical leave to be with their loved one. And then we often tend to put our family members before us when they're not well. So this mom stopped taking care of herself. She says she doesn't have the time or energy to lose weight. I think I'm probably stressed more inside. I feel like a failure as a mother because I can't get rid of the psoriatic plaques. And finally, intimate relationships. This young couple said, I feel like we're living an older couple's life. and our love life has been affected because of my husband's psoriasis. The husband says, my wife feels embarrassed when she undresses me in the bedroom. So this is just a schematic that shows the many areas, mental health, relationships, social life, family planning, and intimacy that affect not just the patient, but also the family member of the patient with psoriasis. So myth or fact, women with psoriasis can have a normal, healthy pregnancy. Let's leave the poll on for a few seconds. I saw there are many answers already. So yeah, let's take a look at our poll answers. I saw many of you had already answered this one. Okay, let's bring up the answers, please. All right. So 87%, and I'm very happy to see this because majority of you agreed that women with psoriasis can have a normal, healthy pregnancy. Yes, it's a fact. So it's important because the wrong information affects people with psoriasis and their decision to have children. In this report on psoriasis and the family, this young lady said, I wanted to start a family, but the doctor said, forget it. And then she didn't have kids. So psoriasis and pregnancy, here are the simple, plain facts. So psoriasis can be treated safely during pregnancy. It's important to inform the doctor if ever planning for pregnancy because the dermatologist needs to avoid certain psoriasis treatments. And Dr. Kirsten will go into the treatment section afterwards in this presentation. But during pregnancy, certain medications need to be avoided. As I told you before, the skin may improve, it may flare up, or it may remain stable during the course of the pregnancy. So on the bright side, we now have many, many safe and effective treatments for psoriasis, which your doctor, your dermatologist will choose and tailor specifically for your type of psoriasis and your lifestyle, and most importantly, your treatment requirements so that you can live the best life. So I'll pass on to Dr. Yo Yi Wei, who will talk about the treatments available for psoriasis. Thank you.
Okay. Okay, thank you, Dr. Sashan, for the interesting talk. So good afternoon, and thank you everybody for joining our webinar today. So in my section of the talk, I'll be talking about managing psoriasis. So I will be sharing on some of the treatment options as well as new treatments, as well as sharing on some tips on skincare in psoriasis. So as we have heard, psoriasis is a chronic inflammatory skin condition which tends to affect very obvious areas such as the scalp, elbows, and knees. It can have a significant impact on the quality of life, and in patients with moderate to severe psoriasis, the persistent scaling and flaking can pose a daily nuisance, cause embarrassment, and can also affect one's social interactions. So furthermore, it is now recognized as a systemic condition with increased risk of metabolic conditions as well as heart disease, particularly if it is poorly controlled. Thus, good control of psoriasis is essential not only to relieve the symptoms and improve the appearance of the skin, but also to reduce inflammation within the body and thus potentially reducing the risk of metabolic disorders as well as heart disease. So how can we achieve good control of psoriasis? So in this segment, I'll be covering some of the current treatments as well as what is new in the treatment of psoriasis. I'll be sharing some tips on skincare in psoriasis, and finally, how we can achieve the best care in psoriasis. So let's first start by how psoriasis treatment works. So earlier on, Dr. Sashan shared that this is an inflammatory skin disorder. Okay, so here you can see that this is driven by a whole lot of inflammatory signals. And this results in an overly rapid growth of skin cells and thick scale accumulation over the skin. And this may be due to triggers such as injury, often in a genetically predisposed person. So our treatment aims to get rid of this rash, either by trying to slow down the rapid growth of skin cells on the skin, or by blocking all the inflammation signals in the skin. So this is a timeline sort of to give you an idea of how treatments for psoriasis have evolved over the last century. So first, we have topical agents such as coal tar. So these have been around since the 1920s and are actually still used today. And subsequently, in the 1950s, we have the topical steroids and subsequently now topical vitamin D as well. Then there was the discovery of oral systemic medication in the form of immunosuppressants as well as retinoids. And phototherapy, or the use of UV light, was also established in the 1980s. So in the last 2 decades or so, we have seen a great developments in the treatment of psoriasis, and this came in the form of biological agents, which are much more specific for psoriasis than the previous oral medications, and thus also much more effective. So moving forward in the last few years, biosimilars have also emerged. So these are medications which are actually very similar to the original biologic. However, they can be produced at a much more affordable level, and this has actually improved accessibility to biologic use over the last few years. And lastly, we have new small molecule treatments as well that have been developed. So very broadly, psoriasis treatments can be divided into these 4 main categories. So the first is topical treatment, phototherapy, oral systemic treatment, as well as biologics. And so we will go through some of these in a little bit more detail. So first up is topical treatment. So this is usually the first line for most patients, and especially in mild cases of psoriasis, where topical treatment may be all that is needed. So commonly used agents include that of anti-inflammatory agents, such as topical steroids. So as you know, topical steroids do come in different strengths, and so this will be tailored according to the thickness of the rash, as well as the site of the rash. In areas where skin thinning is concerned, topical calcineurin inhibitors, which are non-steroidal, can also be used. Other topical preparations include that of coal tar preparations. So these try to work by slowing down the growth of skin cells. However, tar is used much less these days, partly in view of the smell as well as its tendency to stain. So lastly, vitamin D analogs can also be used, similarly also trying to slow down the rapid growth of skin cells seen in psoriasis. However, both of these agents may also cause skin irritation, and thus sometimes vitamin D analogs are combined with topical steroids so that they can be more effective. If psoriasis is very widespread and topical treatment is not practical or doesn't work sufficiently, then the next slide we can consider is that of phototherapy. So we know that natural sunlight has been shown to be beneficial for skin diseases for thousands of years, and this has been harnessed in the form of phototherapy. So we usually use ultraviolet B light, and this is delivered in a light cabin, which you can see in the picture on the right. So because other harmful and ineffective sunlight rays have been filtered out, phototherapy is safer and more effective than using natural sunlight. So the advantage of phototherapy, of course, is that it can treat a large skin area. It is external treatment, so you don't have to worry about eating anything oral and worrying about any internal side effects. However, it is quite time-consuming, as usually patients have to come to a center that does it 2 to 3 times a week for at least 3 to 4 months. So if phototherapy fails, or sometimes due to work commitments, for example, our patients cannot make it for the phototherapy, then we use oral systemic medications, and these are some of the common agents we use, acitretin, cyclosporin, methotrexate, and some other newer medications that we will talk about. So firstly, acitretin is a vitamin A derivative. We call it retinoid, and this is derived from vitamin A. And how it works is that it tries to regulate the normal growth and development of skin cells, so also slowing down this rapid growth of skin cells. The advantage of acitretin is that it's not immunosuppressive, so it doesn't affect the immune system. However, it may not be suitable for everybody. So, for example, it is not suitable for females of childbearing age, and this is because there may be a risk of birth defects, and it does require liver and cholesterol monitoring. Some patients may also get dry skin, nails, and mouth with the medication, although these side effects can usually be managed. The next group of oral medications are that of traditional immune suppressants. So these medications try to reduce the inflammation by blocking the immune system in a non-specific manner. So these immune suppressants can be used for a wide range of other conditions besides the skin. So the two most commonly used agents are that of cyclosporin and methotrexate. So cyclosporin being stronger and faster acting. And so they work very well for flares, but cannot be used on a long-term basis. And then we have methotrexate, which is slower acting, but can be used in the long term. So both of these medications will require monitoring for infection as well as organ side effects, such as the liver, kidney, as well as blood count. However, with appropriate monitoring, they can be used effectively and safely. So what is new for oral medication? So there are two new medications that are recently available. So the first one is called apremilast. So this is a more selective anti-inflammatory agent. So we mentioned earlier on that some of the older ones are not so selective. And the advantage of apremilast is that there are no major organ risk factors, although there are some reports of mood disorders and some people may get gastrointestinal side effects like nausea and vomiting. And the most recently to be approved is called deucravacitinib, quite a mouthful. So this is also a very new, more selective kind of immune suppressant, and this means that the risk of things like infections will be less than the usual traditional oral immune suppressant medicines. Okay, so next we move on to the last class, which is that of biologics. So biologics are probably the most effective treatments for psoriasis at present. So biologics are protein-based drugs that are derived from living cells in the lab. And so they are actually engineered specifically to only target parts of the immune system that are overactive in psoriasis. So that means that they are really much more specific. So because they are more specific, they also tend to be more effective, and they have also less risk of causing problems with things like the kidney, liver, or other organs. So most biologics are given by injection or infusion. So while that might sound a bit scary, the injection is actually a simple one done over the abdomen. So it's similar to what somebody does when they have diabetes and they have to do insulin injections. So this is usually, it can be given at home on your own as long as you learn how to do it. So while biologics in the past used to be much more expensive, biosimilars have now been available for some of these. And then this has greatly brought down the cost of treatment with biologics. So I think Dr. Sachin earlier on shared a busy slide of all the different inflammation signals that affect psoriasis. So this is just to show the different classes of biologics that are available and how they block different inflammation signals. Okay, so we start off with the oldest generation of biologics. So these are the anti-TNF blockers. So they block a signal called a TNF. Okay, and this is followed by those that block the IL-12 and 23 pathways. We have those that block the interleukin-17 or IL-17 pathways. And the newer kids on the block are those that block the interleukin-23 pathways. Okay, so you can see there are actually many biologics that are available for treatment at the moment. And with each generation of biologics, it becomes more effective as well as safer. So how effective are biologics? So this is just to give a gauge. So for an estimated proportion of patients with psoriasis, a moderate to severe psoriasis who have 75% improvement by 4 months. Okay, so this with TNF blocker, about 67% of people will get 75 improvement. 87% of those who take a IL-17 blocker will have 75% improvement. And the percentage is 93% for an interleukin-23 blocker. So this is actually quite a good improvement. When we look at complete clearance, so we are talking about 100% clearance of skin psoriasis, you can see for the anti-TNF blockers, about 17% of patients can have 100% clearance. For interleukin-17 blockers, it's about 35% clearance. And for the interleukin-23 blockers, it's up to almost half of patients can be clear. So biologics can be very effective in the treatment of psoriasis. So while they are very effective, of course, biologics are also not entirely without risk. While they have a very good safety record, there is still a risk of immune suppression, although the risks are less than with oral immune suppressants. So usually we will do some screening tests before starting any of these medications so as to reduce the risk. Certain biologics may also have their specific risks, which your doctors can share with you. And all these medications are still relatively new, so biologics have only been approved from about 2008 to 2019. And so their long-term safety, of course, is still unknown. The other thing to mention is that while there are many biologics, not every biologic necessarily works for everybody. And biologics used over a long period of time sometimes can lose effectiveness as well. Because there is also a lack of safety data and things like pregnancy. So if you are planning to become pregnant, it's good to inform your doctor and to discuss with them whether this will be a suitable treatment or not. Okay, so there are so many options. So how do we choose? Okay, so not to worry, your doctor will discuss with you. Okay, and some of the factors that we consider when we are choosing treatment for psoriasis includes things like the type of psoriasis, how severe it is, and how fast we need control. Whether the nails and joints are also involved, because there are some of the medications that can work for both the skin and the joints at the same time. We will discuss your individual treatment goals because they can look different for many people. We have to consider other medical conditions, and this is because some of the medications that we want to use may interact with some of the conditions that you may have. We have to consider also lifestyle factors, patient preference, so some people absolutely don't like any injections, as well as the affordability of treatment. And so considering all these, we will discuss with you and formulate an individual treatment plan. So now that we have covered most of the treatment options, the next part we will go through is skincare in psoriasis. So how can I look after my skin if I have psoriasis? So as we know, psoriasis skin tends to be very red, flaky, as well as easily irritated. So always use gentle cleansers and moisturizers. So when you shower, always take short showers of less than 5 minutes and use cool or warm water and never hot water. Okay, so this is because hot water may feel very good on the skin when you're using it, but it does cause irritation of the skin in the longer run. Also, it is important to avoid scrubbing. So although sometimes when it's very scaly, we know there may be a temptation to try to scrub off the scales or remove the scales so that the skin looks better. However, when we scrub the skin, we actually traumatize the skin, and this sometimes can lead to flare in psoriasis as well. Okay, so after bathing, gently pat dry the skin. Try not to use the towel and rub excessively. So lastly, after a bath, always apply a fragrance-free moisturizer, ideally within 5 minutes, as this will enable the moisture to be locked in most effectively. Okay, secondly, if you are prescribed topical treatment, make sure you use your topical treatment regularly and adequately. Okay, so what we mean by regularly is to use it every day, okay, until the rash is completely gone. Okay, so try not to use it for, say, 2 days, 3 days. The scaling looks a bit better, the rash looks a bit better, I decide to stop. Okay, because then the rash doesn't go away, it just looks a little bit better, and then when you stop, sometimes it will come back again. So we want to clear the rash completely, and to do that, you need to use the treatment on a regular basis. Okay, so when we mean adequately, okay, how we usually gauge is you can use a fingertip unit. So if you squeeze a standard nozzle from the tip of your finger up to the first crease, so this is 1 fingertip unit. So this is enough cream to cover a rash of 2 palm surface or 1 hand front and back. Okay, so this is what we consider as adequate application. Okay, next is also important to avoid scratching as well as contact with any irritating substances such as by frequent hand washing and other kinds of harsh soaps. This is because psoriasis is known to occur over areas of injury, trauma, or irritation, and this is what we call a Koepner's phenomenon. Okay, so you can see in some pictures here, you can see psoriasis occurring in a line. Okay, so this is usually due to scratching. So it occurs over the site of the scratch. And also you can see on the right, psoriasis occurring due to the injury of the skin from the TCM cupping procedure. Okay, so when you have psoriasis, especially if it's active, we have to be a bit careful of some of these. Okay, fourthly, there's a proper scalp care. So we know that in psoriasis, the scalp can be very scaly, and this scale sometimes can be difficult to manage and can accumulate to a thick layer on the scalp. So it is important to remove the scales in scalp psoriasis before we put topical treatment, because this allows the treatment to better penetrate the skin. Okay, so how we do this? So the first step usually will be to soften and remove the scales. Okay, so you can use things like either cocoa ointment or olive oil, put a lot of it, and then leave it there for at least 2 hours. Better still if you can leave it overnight. Okay, so this helps to soften the scales to allow easy and non-traumatic removal. Okay, next step 2 will be to wash off with shampoo, and you can use a fine tooth comb to try to help to remove the scales. So remember, remove only those that can come out. Don't scratch the scalp and cause bleeding, okay? Because we don't want the scalp to be traumatized. Okay, and thirdly, we then apply the scalp treatments. Okay, so moving on to the last part of the talk. So how can we achieve the best care in psoriasis? So this really comes by managing psoriasis as a whole. Okay, so we not just want to treat the skin psoriasis, but we also must manage other things like the lifestyle factors as well as the triggers. Okay, we want to make sure that the joints are screened and looked after, and also to check and treat any metabolic associations, and not to forget the mental health aspects of this condition as well as the social impact that it may have. So it's very important, okay, to partner with your physician so that they can discuss and help you to manage all of these things, and also form a personalized treatment plan. Okay, so what can you expect from a psoriasis clinic consult? So usually there are a few aspects that we will assess. The first will be a disease assessment. So we want to know how the skin, nails, and joints are doing, how is the symptom control, how is it affecting your quality of life. Okay, then we will choose appropriate treatment considering your medical issues, cost, convenience, and other factors. We also want to know what are your treatment goals, how fast we need a response, and whether it can be sustained. And in the long term, of course, monitoring for side effects, screening for metabolic conditions, and also the lifestyle factors. So I would really like to end off by emphasizing that lifestyle factors can really play a huge role in the management of psoriasis. Okay, so like what Dr. Sashan mentioned earlier, things like quitting smoking and limiting alcohol, both of this has been shown to reduce the frequency of psoriasis flares, and for smoking to also reduce the incidence of heart disease. If you are overweight, then losing weight can help to reduce flares and also make the existing treatment that you are on more effective. And this can be done through exercise, as well as eating a healthy and balanced diet. Because of the risk of metabolic syndrome, it's important to get screened for high blood pressure, cholesterol, as well as diabetes at least once a year. And not to forget managing stress, which is a significant trigger of flares. And one way to do this sometimes can be to join a support group, which is also available with the Psoriasis Association of Singapore. So in conclusion, in the current landscape, psoriasis is actually a highly treatable condition with very good clinical outcomes. And in order to achieve the best care, we will need holistic management to address all these aspects, including lifestyle measures, good skin care, appropriate skin treatments, as well as to manage any associated conditions. Okay, so I hope you have learned something today, and I thank you for your kind attention, and we'll be here to take any questions. I've also included some reading resources for you.
So thank you, Dr. Kirsten, for the very insightful presentation. We shall now move on to the Q&A session for our talk. We'll first start off with the first question for Dr. Session, which many patients have asked. How do you differentiate between psoriasis and eczema? Is it the same?
Right. Thank you. And this is a question that I get asked a lot, even in clinic. So both psoriasis and eczema are skin conditions that involve the immune system, but in two different ways. So you know how we talked about that orchestra, right? There are many pathways in the immune system, and the two different skin conditions are due to two different pathways. There are some features that set the two apart. So eczema, we very commonly see the onset even in childhood. So kids can be born and within the first few months of life, they might have scaly rashes. Some of them outgrow the eczema, but some have it even into adulthood. Psoriasis has usually about two peaks of onset. So first, between the ages of 20 to 30, and then around 50 to 60. Of course, either condition can happen at any time in life, but these are the common peaks where we see the onset. Second, in psoriasis, your inflammation causes the dead skin to pile up, causing these red rashes. Whereas in eczema, the inflammation is triggered by something on the outside. So either an irritant, some environmental trigger causes your skin to respond with inflammation. And eczema patients also have a barrier dysfunction. If you imagine your skin as roof tiles that should be nicely laid out, in eczema, there's a dysfunction in that barrier. So anything can irritate the skin easily. Commonly, they affect different sites. So eczema tends to go into your skin fold. So this part on the inside of the elbow, the fold of your neck. Psoriasis tends to normally go to the outer side. So this part of the elbow or the back of the scalp. But that being said, both of them can behave very similarly. Both of them can, for example, in very severe conditions, give erythroderma or full body redness. So the treatments also can overlap because ultimately they're from the immune system, but it's important to get the correct diagnosis because there are individual treatment options. So that's where your dermatologist comes in. What's the difference in scalp psoriasis and scalp conditions like dandruff and flakes? So in scalp psoriasis, the underlying cause, again, is your immune system causing more and more dead skin to pile up at the back. But there are other scalp conditions. So people with eczema can have eczema on the scalp. And in that case, it's a very different mechanism, like I told you before. So people who have seborrheic dermatitis, which we commonly call dandruff, is when you have inflammation in the scalp, but there's also overgrowth of a fungus, which also makes the inflammation worse. So for the treatment, we have to use an antifungal shampoo in those cases. Other causes of scalp scaling could include a fungal infection where you need an antifungal treatment, or it could be an allergy to your hair dye. So it's very important, again, for a doctor to go through your history to ask you what you're applying on the scalp, look at your scalp to give you the correct treatment because they're very different conditions. And how to distinguish between psoriasis and rheumatoid arthritis. Now, both of these are inflammatory conditions. Psoriasis comes with characteristic skin rashes. I've shown you pictures of those. On the skin, rheumatoid arthritis usually may just show up with some lumps, which we call nodules on your arms, but not really the rashes that you get in psoriasis. Both of them can involve the joints. In rheumatoid arthritis, we call it symmetric, meaning you would very rarely have your rheumatoid arthritis on only one wrist. Both of your hands would be involved, and it's symmetrical. Psoriasis does not act symmetrically. It can affect random joints, little joints on the hands. When you look through an X-ray, that can also show you certain characteristic joint deformities that we see in rheumatoid arthritis versus psoriasis. For example, in rheumatoid arthritis, the thumb may be bent in the shape of the letter Z. We call it a Z thumb, not something that happens in psoriasis. Whereas I told you there was joint destruction in psoriatic arthritis, that essentially can cause your finger joint to shorten and collapse into itself with the joint destruction. So there are a few different factors. These are just some of them between psoriasis and rheumatoid arthritis, but there are two different conditions. All right. And does prednisolone make psoriasis worse? So every now and then, I have a patient who comes in with a very bad flare of psoriasis. And on probing and asking the history, I find out that they were given a course of steroids for treatment of maybe another condition, but it was suddenly stopped. And then the psoriasis flared up soon afterwards. So stopping prednisolone abruptly can cause psoriasis to flare up. So it's very important if you are taking prednisolone for any other condition, to tell your physician. You may be seeing a gastroenterologist for inflammatory bowel disease and taking prednisolone for that. Tell them that you have psoriasis, because if they suddenly stop the prednisolone, your psoriasis will flare up. And that's why we don't really use prednisolone when we treat psoriasis.
Okay, so my question is, what soap and cream can be used for psoriasis? Okay, so I think earlier on we went through some of these. So for psoriasis, usually the skin is very flaky, red, and can be quite sensitive. So usually we want to use gentle cleansers. So when we mean gentle cleansers, usually we mean soap-free, so things that do not contain sodium lauryl sulfate. And we want it to be a physiological pH, which is about 5 to 6 or so. And so most of the sensitive skin brands are okay. You can find them sometimes in the pharmacies. Okay, so you can use these soaps for psoriasis. Okay, so in terms of cream, I presume there are you mean moisturizer creams. Okay, so there are many kinds of creams in the market as well. So as long as we choose a cream that is fragrance-free, as little preservative as possible, so things like paraben-free. Okay, and they are cream form. So there are many types of moisturizers. They can come in lotions, creams, or even an ointment, which is oilier like Vaseline. Okay, so usually we prefer those that are more cream or ointment based. Okay, because they have a bit more of the oil component and a bit less of the water component. Because if there's a lot of water component, then it's not so moisturizing because it evaporates very fast. Okay, so lotions don't work as well as creams or ointments. Okay, so you can choose a cream that you like the texture of and that is affordable. You can apply a lot of it, and it's a sensitive skin brand. Okay, so what diets can help in avoiding diseases? So I think there is a lot of questions on food. So for psoriasis, it is not really considered an allergic condition. So it is not really caused by anything you eat. So this is not really an allergy. So we really want to avoid an overly restrictive diet. However, it's really important to have a healthy, balanced diet. So this includes things like fish, lean protein, fruits and vegetables, whole grains, and small amounts of things like low-fat dairy. And we want to avoid foods that are high in things like added sugar, saturated fats, as well as refined carbohydrates. So things like your white bread, and noodles. Okay, so these foods, firstly, of course, they do not help in the risk of heart disease as well as metabolic conditions. And furthermore, there is some early evidence to suggest that some of these foods may cause increased inflammation within the body, although more research is needed to support this. Okay, so for nail psoriasis, okay. So I think earlier on, there was also a question of whether nail psoriasis can occur on its own without skin psoriasis. So the answer is also yes, it can, but it is really uncommon. So nail psoriasis can be a little bit tricky because for skin psoriasis, we can apply topical treatment to it directly. But for nails, a lot of the time, topical treatment doesn't penetrate the nails very well. So topical treatments are not very useful for nail psoriasis, and neither is phototherapy. So usually if we want to treat the nail psoriasis properly, we will need something systemic. So either the oral systemic medication or biologics. Both of these have been shown to be useful for the control of nail psoriasis. Okay, so there's a question on biologics. It says that we mentioned that biologics is less risky. What do we mean by less risky? Okay. So when we mean less risky, we are comparing these with the oral immune suppressants that we used to use in the past before all these biologics were available. So oral immune suppressants, they actually block a large part of the immune system. So it's not blocking in a specific manner. Whereas for biologics, they try to just block certain inflammation pathways. So just a segment of the immune system that is responsible for psoriasis. So because of that, the side effects, say due to infection, are much less. Because only a small segment of the immune system is blocked, and your body still has the rest of the immune system to fight off all the infections that you may encounter. Okay, so that's what I mean by less risky. The other thing about it being less risky also is that there is less risk of organ involvement. So for example, with some of the old oral immune suppressants, we really have to monitor the kidney and liver function very closely because there is a risk of it being affected. However, for biologics, it usually doesn't pose a major risk to the organs. Because of that, the monitoring also can be less frequent. Okay, yeah, okay. Now, what percentage of people have side effects after using biologics? So it's difficult to give an exact percentage. So that you mentioned, some people may be a bit more prone to getting things like infections. For example, if you are elderly or you have other medical conditions that predispose you to getting infections, then of course you may be at a greater risk than the ordinary population. Yeah, I hope we've answered the questions.
Thank you so much, Dr. Kirsten, for the very interesting and good answers to the many questions that we have. So I think the last question that is on the Q&A is how much biologic treatment costs, the frequency of the treatment if been claimed by MediSave. So this is a very, I think we'll take a whole clinic consult to answer that question. But maybe if Dr. Yeo can quickly bring us through this before we end our session today.
Okay, so the cost of biologic treatment really varies depending on the type of treatment as well as where you are getting the treatment from. So at least in the public hospital, there are biologic treatments that are subsidized. And so because of that, they are actually affordable by most people. But for the exact cost, we probably have to see you in person and explain to you all the different options and costs. In terms of frequency, the different biologics also have different frequency of injection. So this can range from every 2 weeks to every 3 months. Depending on the type of injection that you are using. And in terms of claiming by MediSave, if I'm not wrong, for psoriasis, you can claim MediSave, I think up to about 500 or 600 a year for psoriasis treatment.
Okay. Thank you everyone for joining us during your precious lunchtime for this webinar. I hope we've answered your questions, and thank you for joining us again. Thank you all.
Okay, thank you.